COVID-19 grand rounds. I am really excited to have some great speakers today. My name is Amy Case, and I am a pulmonary critical care specialist at Piedmont Healthcare. And I'm going to be moderating because I know less about this stuff than our infectious disease colleagues. So we're going to spotlight our ID teams today. We heard from critical care last week about the critical care aspects of COVID-19, some of the things that we're observing and what we know to do and what we're learning to do. And this week, we're going to talk a little bit more about COVID-specific therapies. I have a great panel to introduce today. I'll tell you a little bit more about them as we go forward. Jesse Kalk from Atlanta ID Group in Piedmont, Anesh Mehta from Emory, Vince Marconi from the VA Medical Center and Emory University, and Xanthia Wiley, also from Emory. Just by way of information during this session, the audience here is muted by design. So when everybody logs on, they'll be muted. So please continue to stay muted through the session. And if you have questions or comments, there is a chat box that you can use and you can drop your questions there. And we'll try to address them towards the end of the session here. Just for me, since I'm talking relevant disclosures, that I have research relationships with both Gilead and Kinevant. And just by way of introduction, I think the therapies that you'll hear talked about today are addressing different phases of the body's response to COVID-19. The viral phase, transitioning into an exuberant inflammatory response in those people who tend to get a bit sicker and we see more frequently in the hospital. And so we've grouped the talks that will be given today really on those different phases. And so we'll hear more about that. Now, if you've been paying any attention to traditional media or social media or any politician these days, you will have heard a lot about drugs and treatments that maybe could treat COVID-19. This is from a Politico article just from a few days ago, which I thought was really interesting that they chose hydroxychloroquine as their first picture in that article. Made me look a bit like this at this point. But I will say that there is a lot of development in this area. Just a really unprecedented level of collaboration and coordination that's led to now over 1,200 studies on clinicaltrials.gov that are listed worldwide for COVID-19 and 173 clinical trials just in the United States. That says 250 there, but 173 of these are actual clinical trials that are looking at specific interventional therapies. So I think this is a really exciting time to be in medicine, to be in science. And so I'm gonna, without further ado, let my colleagues get started and tell you what they know about what's going on in the world. First up is Jesse Kalk. Jesse, if you wanna steal the screen.
Sure.
He is the chair of infectious diseases at the Shepherd Center. He's the clinical director of infection control. He is also the Assistant Clinical Director of Infection Control at Piedmont Atlanta Hospital and a member of the Infectious Disease Clinical Governance Council for COVID-19 for the Piedmont system. So welcome, Jesse, and thank you for joining us.
Absolutely, I'm glad to be here. Thanks for inviting me. So yes, today I'll be talking about the rise and fall of hydroxychloroquine. And just briefly, I have no conflicts of interest to declare. So I'm going to begin by introducing both chloroquine and hydroxychloroquine. We'll go over the in vitro evidence of antiviral activity with these drugs against SARS-CoV-2. And then we'll look over some of the clinical evidence for the utilization of COVID-19. And finally, I'll give a summary and recommendations. So chloroquine was discovered at Bayer in 1934. And hydroxychloroquine was synthesized from chloroquine in 1946. Hydroxychloroquine is thought to be more readily soluble than chloroquine and perhaps less toxic. Both drugs were used primarily as anti-malarial medications. And it is important to understand how these drugs work, or one of the reasons why these drugs work as an antimalarial, because it does lend itself to how they're active against viruses. At physiologic pH, these drugs are uncharged and can permeate plasma membranes. But in acidic environments, like you might find in a lysosome or an endosome after a virus goes through endocytosis, or in the malaria parasite, these drugs become protonated and therefore charged, and they are unable to escape. So they accumulate in those environments. And that's one of the reasons why this drug is effective against the malaria parasite. Over time, as resistance developed, chloroquine became less useful and went out of use. However, as these both chloroquine and hydroxychloroquine have immunomodulatory effects, hydroxychloroquine in particular continues to be utilized, particularly in patients who have lupus or rheumatoid arthritis. And these drugs were, and hydroxychloroquine in particular, was shelf ready, something that we had available. And that's important. That's a big reason why there was particular interest early on for treatment of SARS-CoV-2. So let's talk a little bit about the antiviral activity. So there are a number of proposed sites of action against SARS-CoV-2 for chloroquine, but the best understood is here after endocytosis in the late endosome. Again, hydroxychloroquine and chloroquine are felt to be accumulated there and actually increase the pH, which will inhibit pH-dependent steps in viral replication. And this gives these drugs broad in vitro activity against a number of viruses, including HIV and, importantly, SARS-CoV-1. And it's that activity against SARS that led to its interest in use in China early on during the outbreak in Wuhan. This study was published electronically February 4th and looks at in vitro activity in cell lines. In the pink, we have percent inhibition, and in the blue boxes show cytotoxicity. And the goal is to find a drug that has good inhibition, greater than 90% inhibition, and minimal cytotoxicity. And two of the drugs were identified in this study as being potentially effective, remdesivir and chloroquine. And one of these drugs was readily available, and that's chloroquine. Now, the question is, we think of hydroxychloroquine as largely working the same as chloroquine, but additional studies did show in vitro evidence against SARS-CoV-2 as well for hydroxychloroquine. So let's go over the clinical evidence. In February 15th, findings of chloroquine treated in over 100 patients in China were given at a conference. And it showed a significant improvement in those patients. And because of that, chloroquine was added to the guidelines for treatment of COVID-19 in the People's Republic of China. And from this letter that was published, we found this drug on the guidelines in numerous other countries, particularly in Europe, on the onset of COVID-19 pandemic. In February, I tried to find this study and I could not find it. I waited patiently, but as of today, this study with these patients is not yet available. It's not clear that this will ever be published. So one of the first important studies that really showed early promise was a study that in Marseille, France. And this looked at primarily hydroxychloroquine, but also hydroxychloroquine with the addition of azithromycin. They had 42 patients, 26 who were treated with hydroxychloroquine and 16 controls. And then 6 of those patients who received hydroxychloroquine also received azithromycin. And you can see in the chart that patients who received hydroxychloroquine and azithromycin appeared to have, those 6 patients appeared to have a significant decrease in the percentage of positive PCR results as compared to controls. And even in the hydroxychloroquine arm, they saw a significant decrease in the PCR. And it was from this study, we began to find not only hydroxychloroquine, but hydroxychloroquine and azithromycin appearing on the guidelines at several prominent institutions in the US, including Mass General Hospital. But along with early interest in the study came critique. So there are a number of critiques of the study, the first of which is that it's not randomized. A second is that there's data that they state that they obtained, including data for days 7 and 14, that did not appear on the chart and was not discussed. Additionally, controls were from different hospitals, and some of those patients not only did not fit the inclusion criteria, but it appears that a different PCR test was used. And then there's the issue of 6 missing patients in the hydroxychloroquine arm, importantly 3 who were transferred to the ICU and 1 who died, and the question of including these patients, what would that have done to our data? Importantly, while this study was published, one of the authors was also the director or the editor-in-chief of the journal that accepted the paper. And ultimately, this study was retracted on April 3rd. One more early study that showed potential benefit was this one that looked at 62 patients in Wuhan, China. And they saw significant improvement in time to clinical recovery, including resolution of fever and cough, as well as improved imaging. And they did note that no patients progressed to severe illness in the hydroxychloroquine arm. They could not perform statistics, but that was a finding on this. And I'll note that the rest of the studies that I will be presenting are not published and were not peer reviewed. So putting these studies into a table, we see our studies that show early promise. I've listed the study first author, the date when they first appeared, if they were published electronically, the number of patients in the study and whether or not they were published, whether they were randomized, and the outcome. And so again, we have some early promise with these first 2 studies, but subsequent studies later released in April showed some conflicting data. So the first study, the third there, 150 patients treated at multiple centers in Wuhan, China. This was an open label randomized study that compared patients receiving hydroxychloroquine to standard of care. And they did not see an improvement in viral shedding, and they did not see improvement in symptoms. The fourth study occurred in China. It was among 181 patients. And at 28 days, they saw no improvement in mortality, no improvement in the development of ARDS, and no improvement in viral shedding. And finally, the last study was done at VA hospitals in the United States. It's our largest study at 368 patients. They had 3 treatment arms in this study. So one arm received hydroxychloroquine, another arm received hydroxychloroquine plus azithromycin, and the third arm received standard of care. Patients receiving hydroxychloroquine actually showed significantly increased mortality compared to controls. They also saw increased mortality that was not was not statistically significant in patients receiving hydroxychloroquine and azithromycin compared to controls. They did not see a difference in need for ventilation between the groups. So again, I want to underscore at this point in early May, we don't have adequate clinical evidence for the efficacy of hydroxychloroquine for the use in COVID-19. And that is important because we know that chloroquine and hydroxychloroquine are not benign drugs. One of the most significant short-term side effects is QTc prolongation. And there were 2 studies that were published just this past Friday looking at this. The first, Mercuro et al. Showed QT prolongation of a median of 5.5 milliseconds compared to 23 milliseconds in patients receiving hydroxychloroquine plus azithromycin. So they really show that azithromycin seems to worsen that QT prolongation when added to hydroxychloroquine. Among 90 patients, one of the patients actually developed torsade de pois, and 19% of patients had QT prolongation greater than 500 milliseconds. The second study, Basir et al., showed 36% of patients had a QT greater than 60 milliseconds or QT greater than 500. And the median there was 35 milliseconds. They did not separate hydroxychloroquine from hydroxychloroquine plus azithromycin. in those results. But you can see from the data from the study, almost every patient had an increase of QT prolongation. Beyond QT prolongation, there's also risk for psychosis, hypoglycemia. There have been case reports of patients with G6PD deficiency developing hemolysis on hydroxychloroquine. There's risk for bradycardia as these drugs interfere with the degradation process of metoprolol in the body. There's, like any drug, there's risk for a drug rash. Now, some people are taking hydroxychloroquine chronically as long-term prophylaxis to prevent COVID-19, and there are significant long-term side effects, including retinopathy and cardiomyopathy. Finally, on March 28th, the CDC issued an alert after two people ingested chloroquine phosphate intended for aquarium use. One of those individuals died shortly after presenting to the hospital, and the was in critical condition, although they did recover. And one last study, this study looking at high dose versus low dose chloroquine was terminated early in Brazil because of toxicity in the high dose arm with decreased percent survival. And they did see a 19% of patients develop a QT greater than 500 in the high dose compared to the low dose arm of 11%. So again, we have a drug without clear benefit and there are clear risks. And when it comes to recommendation, I think that we really need to underscore that. I think we should, at this point, the way we think about using hydroxychloroquine should be do no harm. First principles dictate that if you have a drug with no known benefit and clear risks, then you should not use that drug. And at this time, Infectious Disease Society of America only recommends the use in the context of a clinical trial where you can assess for those things. Additionally, I do not recommend adjunctive oral azithromycin, as we have clear evidence it increases the QT beyond just hydroxychloroquine alone. The benefit's unclear. The study that prompted its use was retracted. The book's not written on hydroxychloroquine. On clinicaltrials.gov, there were 153 trials throughout the world investigating hydroxychloroquine as an intervention. And again, going back to the slide that Dr. Case showed, in many cases, we're using this on patients who are severely ill, and it's not clear that the virus is causing the illness and that antivirals would be effective at that stage in the illness, as opposed to the immune system causing the illness. Certainly, some have proposed that hydroxychloroquine has immunomodulatory effects, but that's not really why we're using hydroxychloroquine. We're using it primarily because of the in vitro evidence against SARS-CoV-2. But early prevention is an interest, and so there are 22 registered trials, and at least 5 of these are located in the United States, looking at hydroxychloroquine as prophylaxis. The first 4 of these studies are for use in healthcare workers, and it's possible to sign up for some of these studies if you have a concern. Now, I'll caution that there have been anecdotal reports of people who have autoimmune disease and take hydroxychloroquine chronically who still get SARS-CoV-2. In fact, there was a case report published on April 28th, a patient on chronic hydroxychloroquine who developed SARS-CoV-2 infection. I thank you for your time today. I've included my contact information if you have any further questions, and I'll let Dr. Mehta talk about about remdesivir.
Thanks, Jesse. That was great. While Anesh is getting his slides up, Anesh Mehta is Chief of Infectious Diseases at Emory University Hospital. He's the Assistant Director of Transplant Infectious Diseases and also works in the Emory Serious Communicable Diseases Unit. He serves as Emory's PI for the NIH Adaptive COVID-19 Treatment Trial, or the ACT study, the first phase of which has shown those positive results with remdesivir that we've all heard about. So he'll be talking today about antiviral therapies for COVID-19. Welcome, Anesh, and thank you so much.
Thank you so much, Amy, for that introduction, and I'm happy to be here today talking on behalf of a very large group of many people who have been working on antivirals for COVID-19. So I have no pertinent financial disclosures. I do receive some research funding from the NIH related to COVID-19. I do have previous research funding from these organizations listed here, but none of them are related to COVID-19, nor are they related to any of the data that I will be showing. So I think we're going to spend most of the next several minutes talking about remdesivir because that is all the news these days. So remdesivir is a nucleoside analog of adenosine that interferes with viral RNA-dependent RNA polymerase. As you can see here, there is a protide piece on there that is making this a prodrug when it's administered, and then it gets converted into the active form. It was initially developed in a library looking for drugs against hepatitis C. It was not found to be very effective, sort of sat dormant for a while. And then it was resurrected in 2015 as a possible treatment for Ebola. Unfortunately, though there was a lot of interest at the time, by the time it made it to human pharmaceutical use, the outbreak had pretty much gone away and it couldn't be tested very efficiently. In the meantime, some investigators developed some data that it had activity against other coronaviruses, such as SARS-CoV and MERS-CoV, and there was interest in doing clinical trials with it, but there were not enough patients to do so. And then again, it stayed dormant until 2019, during the DRC Ebola outbreak. It was integrated into a large adaptive clinical trial that was headed by the NIH, WHO, and multiple organizations that looked at 4 different drugs, ZMapp, remdesivir, and 2 monoclonal antibodies. And as many people may have heard, remdesivir was found to be safe in that trial, but not nearly as effective as the other 2 drugs that were, the monoclonal drugs that were used to treat patients with Ebola. In early 2020, once SARS-CoV-2 was identified, investigators, particularly at Vanderbilt and other institutions who had this drug available, started quickly testing it against SARS-CoV-2, and there was some indication of good activity. It's also important to note this drug is only available as an IV. This is a little cartoon that I borrowed from a website called Microbe Notes, and it was developed by a group of people using a program called BioRender. But this just shows the drug remdesivir as its prodrug, and then gets converted into this active molecule, which then has an effect. As most of these antiviral, direct-acting antiviral agents which interfere with RNA polymerase, it tricks the ribosomes into integrating this analog and therefore inhibiting the production of multiple proteins of the virus. And this is how it works for coronaviruses. This is also how it potentially works for flaviviruses and other viruses. So now getting to the clinical trial that Amy mentioned I had the opportunity to be a part of. This is the NIH Adaptive COVID-19 Trial of Therapeutics, otherwise known as the ACT trial. It is an adaptive, randomized, double-blind, multi-centered trial to evaluate novel therapeutics in hospitalized patients. And the main purpose of doing this trial is to examine these novel therapeutics because there are no proven or approved therapeutics for coronavirus still today. So Emory got the opportunity to be a launch partner for this trial due to our involvement in both the NETEC, which is the National Emerging Special Pathogen Treatment Education Center Network, and the Vaccine Therapeutics Evaluation Networks, which are 2 phenomenal networks of both for clinical care and for clinical research. So Act 1, which has just completed and has been on the news recently, is standard of care plus remdesivir versus standard of care plus a placebo, and basically IV fluid. So the initial goal was to enroll 440 patients in approximately 3 to 4 months. They were thinking potentially it might even take longer. University of Nebraska Medical Center enrolled its first patient on February 25th. Over the next several weeks, 68 sites were onboarded, 47 of which were in the United States. And we ended up enrolling as a group 1,063 patients over 2 months, which I think was a remarkable feat of not only giving the access to science to this number of patients, but collecting this amount of data in such a short period of time in the setting of a large outbreak that was significantly impacting not only our ability to care for patients, but also the ability to do research, given the limitations of PPE, personnel, and supplies. We were fortunate at Emory to enroll 103 patients distributed across 4 hospitals in our system, and really just saw amazing work at each one of these institutions in the care of these patients, but also in ability to do research with these patients. And I just want to take a quick moment to highlight our amazing team of research coordinators, pharmacists, infectious disease colleagues, ICU nurses, floor nurses, ICU hospital medicine doctors, and many, many other people that really were able to bring this work together and enable us to actually have some data about a therapeutic. And so now getting to that data. So interestingly, the preliminary data was released on April 28th, shortly after the DSMB met on April 27th at a White House press conference, which is not usually the way that scientific data is released to the public, but we are living in different times. And these data were originated from the Data and Safety Monitoring Board that looked at just under 500 recovered patients. And recovered in this trial is defined as being well enough to be ready for hospital discharge. So these preliminary data showed that patients on remdesivir had a 31% faster time to recovery than those that were treated with placebo. And again, with these preliminary patients, that was statistically significant. And that equated to a median time of recovery of 11 days with remdesivir treated patients to 15 days those treated with placebo. With that information, sorry, I should go on. There was an analysis of mortality as well, which is one of the outcomes that we had been monitoring. And mortality was 8% with remdesivir versus 11.6% with a placebo group. Definitely not statistically significant. So we cannot say that there's any difference in mortality between these two groups. Again, we are still awaiting the full data of the 1,063 patients. We're still actively following many of these patients to their study conclusion at day 29 here at Emory and multiple other institutions. And this will give us far more data about safety, other secondary endpoints, and also make sure that this data of recovery time is still statistically significant. However, it was felt that this was enough data for the DSMB to inform the investigators that they did not believe going forward any remdesivir studies by the NIH should have a placebo arm in it anymore as we were designing the next trial. And they also gave us the option to decide whether to unblind patients that were in the hospital still and were critically ill, which we all decided would be the ethical and prudent thing to do. And that was done shortly after we received the data. This is definitely not a grand slam or a magic bullet, as has been mentioned multiple times. I think a decrease in recovery time is significant. This gets patients home more rapidly to their families. It also prevents some of the complications of being in the hospital for a prolonged period of times. And importantly, for those of us caring for COVID-19 patients who have a limitation of beds for COVID-19, it allows us to have more ability to take care of these patients, more of these patients over time. So I think it does have some good potential, but it is definitely not a cure and definitely not a remarkable magic bullet type therapy. I will also comment, there is only one peer-reviewed comparative clinical trial of remdesivir. in COVID-19 patients. And that's this published in Lancet that was developed by a group of researchers from China. And just in summary, they did not find any statistically significant clinical benefit of remdesivir in their patients. There are some interesting caveats to this data. They did not meet enrollment criteria or enrollment targets. They only got 237 patients enrolled. They were aiming, I believe, for around 350. They also randomized 2-to-1. So for every 2 patients getting remdesivir, 1 got placebo. And that actually makes some of the statistical differences more difficult to achieve than to 1-to-1 randomization. In their supplementary data, though, there are some interesting findings that, that I like to point out, is that they were looking on a Kaplan-Meier plot, the time to clinical improvement, and comparing those patients that had less than 10 days of illness at the time of enrollment versus those that had more than 10 days of illness. And as you can see, those patients that had more than 10 days of illness by the time they received remdesivir, there was no real difference in their outcomes. However, if you look at this panel of those patients that were treated with remdesivir earlier in their course of illness, you are starting to see a separation in their time to improvement in those treated with remdesivir. So these data, I think, would indicate that earlier that we can get patients on remdesivir, probably the better. And that's true for most antiviral therapies. The earlier you can start them, you lower the set point of the virus, you lower the post or the contemporary and post-viral inflammation that's induced, and therefore hopefully have a greater benefit to patients. Okay, so where's the future? We still have many, many questions. So I think we have some answers, but that leads to far more questions. So in which patients does remdesivir work best? Does it work better earlier in disease? I think we have a lot of indication that yes, that's probably true. Does it work in patients that are already intubated and are needing a lot of oxygen support and or ECMO? Does it work in patients that are older versus younger? I think that's all data we need to get from the larger data set. Will remdesivir combined with something else bring down the mortality? I don't think any of us are happy with an 8% mortality. I think we would like to see that being a lot lower. And so I think there's a lot of opportunity to study other medications, particularly combined with remdesivir. And one of the areas that we're really interested in is immune modulators with remdesivir. Are there other antiviral medications that may work better? I think remdesivir may have a continued benefit, but there may be other antivirals that may be better or may be easier to give than remdesivir, which is only available by IV. As you guys may have heard, there was an FDA-issued emergency use authorization. What we still don't know is what are the definitive criteria for its use. We do know that they want it to be used in hospitalized patients that are critically ill, but what defines that and where will they allow that to be used? And then more recently, you may have heard that Gilead was asked to give up control of their remdesivir supply to the executive branch of the government. So we still have questions about who decides where the drug goes and what hospitals will get it. Many of us know here in Metro Atlanta, at least up front, we will not be getting any remdesivir under the EUA, but we don't know which hospitals will get it and which criteria are used for this. So moving on to the next phase of this adaptive clinical trial. So again, based off of the DSMB recommendations on the Plumeria Data, a pure placebo arm has been completely removed from Act 2. And Act 2 will now go on to look at the addition of an immune modulator, which is likely to be baricitinib, to remdesivir for hospitalized patients with COVID-19. We will randomize 1-to-1. The inclusion criteria will be the same, patients that have a positive SARS-CoV-2 test, plus pneumonia and or needing oxygen support, mechanical ventilation, or ECMO. Given that we're adding a JAK inhibitor or some sort of immune modulator, we're also going to have to monitor and exclude patients with low white counts or lymphopenia, We have to exclude patients that are receiving cytotoxic or biologic treatments either concurrently or within the past 4 weeks. And also, given that some of these agents can increase the risk of thrombosis, patients that have repeated thromboses or recent or active thrombosis will need to be excluded from the trial. There are other antivirals that are out there and I think still need to be studied. One of the ones that has been of a lot of interest recently is favipiravir, otherwise known as T705, or now as branded Avigan. It was developed by Fujifilm in Japan as a pandemic influenza preparedness medication. It inhibits viral RNA dependent RNA polymerase, just as many of these others do. And there are several ongoing trials, and some of them in combinations with other medicines. There's a BioCryst drug called gadolizavir. Most people know it as BCX4430. There's a lot of interest during Ebola in this medicine as well. It's a broad spectrum antiviral medication. And currently there's they just finished phase 1 studies where it seemed to be fairly safe. And there's a COVID clinical trial in Brazil currently. There is also an additional medication, which is very early, but I get asked a lot of questions about this, that was developed by the Emory Institute of Drug Development and an organization called DRIVE. This is molecule 2801, otherwise known as EIDD 2801. It is an oral direct-acting antiviral analog, just as the other ones we've mentioned, that was really being developed actually for arboviruses such as Venezuelan equine encephalitis and Eastern equine encephalitis. But they did have some activity from previous experiments showing killed SARS-CoV-1 and MERS-CoV. And so they did some quick tests on SARS-CoV-2, and it is now in phase 1 trials in the United Kingdom. And if that data looks like it's a safe medicine, hopefully this summer it'll move into phase 2 trials. Okay, with that I want to end, but I did want to talk, just say a thank you to all of our patients and their families who contributed to the science that I presented here and have been wonderful partners in this research. We could not do any of this without our amazing research teams, our coordinators, our nurses, our doctors, every pharmacist, everyone involved. And then our wonderful care teams, all the doctors, nurses, pharmacists, respiratory therapists, and everyone else involved in COVID care. I want to give a special Happy Nurses Week to all of our nursing partners who have helped us take care of these patients. And thank you very much.
Thanks, Anesh. So next we're going to move into some immunomodulatory therapies for COVID-19. And Dr. Marconi is going to tee up his PowerPoint. Vincent Marconi is a professor of medicine and global health at Emory University and an infectious diseases physician at the Atlanta VA and Grady Hospitals, and is the director of the Atlanta VA Infectious Disease Research Program. So welcome, Vince, and I can see your screen.
Thank you. Can you hear me?
Great. We can hear you.
Terrific. Thanks so much, Amy. And real pleasure to be a part of this discussion and great talk so far from Jesse and Anesh. First kind of caveat to say, although I'm speaking about immune modulators, I began my scientific career as a virologist. And I would say the last 15 years, despite being in infectious diseases, have learned a tremendous amount about the immune system, in particular about inflammation. And I think it thankfully has served well, at least with this current epidemic. So like many of you, I've spent a lot of time around my children, so I feel my work has been influenced now more than ever before COVID, or as my son calls it, BC. So you may see some subtle inspiration in my slides. So to bring up this, again, the slide that Amy showed at the beginning to sort of remind us as to why immune modulatory therapy is important. I won't spend much time on this because I think many of us have looked at this over the past several months since it came out. But kind of thinking about the transition that happens after kind of the initial viral replication phase begins here early on in infection. And then as the time course progresses for at least probably 15 to maybe 20% of patients that get the infection, there will be some degree, and again, that's of people we know who have been infected, who are symptomatic and presented to care. A percentage of those will go on to a pulmonary phase, and then amongst those patients, some will go on further into this sort of hyper-inflammatory phase, which we'll focus on a fair amount. But before going further into that, I think it's worth sort of thinking through one of the major complications that we all have seen, and this is this sort of microthrombotic process that, again, many of us have looked at and explored in sepsis and other autoimmune types of conditions. But this was relatively unprecedented, at least for what we've seen with COVID-19. And so what we believe happens here, one of the kind of major triggers is this binding of SARS-CoV-2 as a virus to the ACE2 receptors, which are located in the lung, in the gut, brain, testes, et cetera, and the kidney. And when that binding occurs and the virus gets internalized into the cell, this results in a lower expression and surface expression and utilization of ACE2. And as a result, there's a buildup of angiotensin 2 and a decrease level of angiotensin 1,7. And as a result, that creates a significant increase in reactive oxygen species and a decrease in vasodilation. That alone causes thrombotic environment, as well as platelet activation that occurs in a complement cascade that ensues, both of which are exacerbated again by inflammation, as you can see here. So not only processes that can result in hypotension, fever, and some of the many syndromes that lead to a classic ARDS picture, but also this microthrombotic event seems to be exacerbated by inflammation. So this is a sort of schematic showing how does this inflammatory syndrome get started? Why does this happen? Again, for patients, a small segment of patients who end up getting SARS-CoV-2 infection. As we mentioned, as the virus is taken in, a large percentage of these are internalized in pulmonary tissue. What usually happens at that point is the innate immune system responds with interferon, type 1 interferons, which are alpha and beta interferons, and then can try and control the virus, just stopping at the innate immune system. Macrophage, natural killer cells also are recruited in this sort of host antiviral campaign. But for a percentage of patients where this doesn't occur, where there seems to be a delayed or ineffective antiviral campaign, there appears to be a prolonged infection leading to more recruitment of the adaptive arm of the immune system. Helper T cells become involved. There's a much greater robust expansion of plasma cells and B cell expansion, where you get a greater amount of antibody production, as well as expansion in helper T cell subtypes. One primarily focused again on trying to rein in infection of cells in the lung and elsewhere in the body, in the gut. This then sets off a cascade of events resulting in the cytokine release storm, where you see IL-1, IL-6, and GMCSF, tumor necrosis factor, all of which result in this massive inflammatory setting, ARDS, septic shock, kidney failure, et cetera. And so what has occurred over the past several months are efforts to look at trying to bring down this inflammatory response. This was also done during the SARS epidemic. It's been looked at in COVID as well, but really an unprecedented opportunity to see whether we can make better progress with this disease in trying to cool down that inflammatory response, which is largely responsible for trips to the ICU, intubation, and ultimately death. So we're going to talk about a few of these, again, in a little bit more detail with the limited time that we have, but really just to give you an introduction to what's being done across the board. So the first one I want to talk about, who's really kind of led the charge here early on, are the IL-6 and IL-6 receptor blockade. These are probably most familiar to folks listening on the call today, including tocilizumab, cetuximab, and sarilumab. Cetuximab is really the only one. It's a chimeric antibody that's directed directly against IL-6, where the other two, tocilizumab and sarilumab, are focused on, these are humanized monoclonal antibodies focused on IL-6 receptor. And they've been used and explored both in clinical trials and in treatment settings to treat multicentric Castleman's disease, some cancer, various cancers, rheumatoid arthritis, systemic onset juvenile idiopathic arthritis, as well as the CAR-T cytokine release syndrome, which is actually probably most similar pathogenetically to what we see with COVID, as well as giant cell arteritis. Some of the weaknesses, adverse events, and other challenges with this drug include hypersensitivity reaction, which can occur with antibody-mediated therapy, increased lipids, infections that have even resulted for some to have black box warning, although that's usually seen for longer-term treatments, rash, edema, etc. They are available both in, depending on the drug, in IV and sub-Q formulations, and do have liver clearance, so there can be drug-drug interactions. There haven't really been a lot published to date on these drugs, and tocilizumab has the largest experience. These are 3 clinical trials that have been done, largely single-arm, open-label trials that exist to date, mainly experience in China. These 3 papers showing you here peer-reviewed studies, Luo and Zhu from China, and then the Pereira experience from New York. These are small studies, again, largely retrospective or open-label types of studies where patients were given these immune modulator therapies to see how they would respond. Most of the populations were similar, having underlying diabetes, hypertension, et cetera, and COPD as underlying clinical disease. And the age has been roughly the same, although this study by Luo et al. Had a bit of an older group. Again, Luo and Zhu had similar breakdowns for male, where the New York experience had more women enrolled in that study. The study from Pereira et al. Actually was from a post-transplant population. On average, they were about 6.5 years out from their transplant. And so many of them had been on steroids or on various other immune modulator immunosuppressant therapies prior to getting SARS-CoV-2 infection. For the Luo breakdown of their clinical severity, 47% of them had critical disease, 40% were serious, and 13% were moderate. And you can see their level of IL-6 here was well above normal, which can be anywhere from 1 to 15 or 20 picograms per mil. They were given 80 to 600 milligrams, and most of them had a dose, maybe a little more than that. About 33% had 2 or more. And they were all, or at least half of them, were given methylprednisolone. So in this population, 20% of them died. 80% remained at the time of submission, remained as inpatients. And the vast majority of them did experience a decrease in IL-6. The paper by Zhu et al. Actually had a slightly less critical population. 19% were considered critical, meaning ventilated and having signs of either ARDS or sepsis. 81% were in the serious category. And again, similar IL-6 levels were elevated. All of these patients received a single dose of 400 milligrams and had been on Kaletra as well as steroids. In this population, none of them died, and 90% had been discharged at the time of submission. So this appeared to be a better population, at least from this single arm experience. And if you look at the bottom, there's a really impressive decline in CRP, which you can see in the left bottom panel. temperature curves very much dramatically in the first day or so, reduced down to normal limits, and then consequent decreases in FiO2 and increases in oxygen saturations were seen over the 3 or 4 days after that. And then finally, the New York experience. This was a much smaller number of patients relatively than the Zoo paper, but was also mixed with other therapies that were being given beyond the tocilizumab. 30% of these patients were severe, 15% were moderate, and they were given 400 milligrams, or the equivalent of 8 milligrams per kilogram, with a max of 800 times just a single dose. There were antivirals, including hydroxychloroquine, that were included in this, plus methylprednisolone. Here they had about the same number as the Luo paper, 24% did die, and here they had 54% discharged, and a few had to be readmitted. So again, as a single arm experience with some mixed background, there does appear to be some changes, at least relative to cytokine measures. So this next category is going to probably seem a bit strange to many of the doctors and other providers here. This is IL-1 blockade. There are two major drugs being looked at now in COVID. Canakinumab, which is a Novartis compound in the CAN Corona study. This is a subcutaneous 26-day, every 26-day therapy in general, usually. And this one binds mainly to the IL-1 beta, rather than actually binding to IL-1 alpha as well, which anakinra is an agonist itself. It's not a monoclonal antibody, but it actually blocks both IL-1 beta and IL-1 alpha. These are used primarily in periodic fever syndromes and hemophagocytic syndrome as well. And that also has a pretty good relationship in thinking about COVID pathogenesis. We do know that in particular, ferritin levels can be quite elevated in that setting. And so looking at this experience in secondary hemophagocytic syndrome, which was due to a lot of other underlying diseases, including infection, there seemed to be reasonable resolution of symptoms here. However, there are some side effects, including headaches, again, lipid elevations and infections over the long period of time, as well as cytopenias. And potentially with anakinra, there's a question of maybe cancer development. This next group of drugs is sort of clawing its way to the throne. Really interesting, I think, in some of the studies that are being done currently at Emory, including gemcitabine and linzilumab, is to block GMCSF. The GMCSF is an upstream cytokine that largely affects mononuclear cells, myeloid cell activation, as you can see here, which results in, again, the same cytokines that are affecting the cytokine release syndrome, including IL-6, IL-1 beta, tumor necrosis factor. It's been used to treat ankylosing spondylitis, as well as, again, CAR-T-related cytokine release syndrome, rheumatoid arthritis, etc. Its advantages are, for one, it acts in CNS and gut, also is active against Th17 cells, which are a big driver of cytokine release syndrome in COVID as well. It does have some hypersensitivity relationships, and also seeing shortness of breath, and does have some requirements, obviously, of intravenous delivery. Some of the, at least preclinical data, shows dramatic decline in xenograft mouse models of GMCSF in the mice given CAR-T therapy. And you can see a dramatic reduction in these heat maps across many of the cytokines, both human and mouse in these xenograft models, and dramatic improvement in change in weight status for the animals that were given GMCSF, but no clinical data as of yet to show this in COVID, so stay tuned. This is a real marvelous class that Anesh was able to talk about potentially being used coming up in randomized clinical trials, but this is JAK blockade. This drug is more of a root sort of blockade, because it results in many cytokine signaling pathways, including IL-6, IL-1, tumor necrosis, GMCSF. It's probably one hole is tumor necrosis factor, GMCSF is blocked, but is IL-17 and tumor necrosis factor. It does block interferon gamma, which is responsible for a lot of the pathogenesis in COVID-19, but not as much blockade of as in interferon alpha, which tends to be the main driver of the antiviral host campaign. So maybe won't have as much of an immunosuppressive effect on the virus itself. And interestingly, in Lancet article from February came out showing an in silico study that actually baricitinib may have antiviral activity against some of the internalization endocytosis of SARS-CoV-2. And this has now been borne out in a host in vitro studies as well at nanomolar concentrations that baricitinib may also prevent internalization of SARS-CoV-2 into host cells. This wasn't seen as dramatically in the other JAK-STAT inhibitors, but again, remains to be seen if this is a real clinical effect. There have been a couple of single-arm trials showing use of baricitinib out of Italy. This one here had 12 patients, showed dramatic improvement, again, compared to this time historical controls, given Kaletra only in ICU admissions and in discharges. In this other yet unpublished study from Italy of 4 patients, you can see dramatic, again, declines in this single arm experience of viral replication in these 4 patients using both NP swabs, blood, as well as IL-6 levels. There are, again, concerns with infections and thrombosis, as Anesh mentioned, has been found usually over longer periods of time in usage, as well as cytopenias. And ruxolitinib does have liver clearance, so there are cytochrome P450 interactions, whereas baricitinib is renally cleared and doesn't have those drug-drug interactions. Anesh mentioned this trial, so I won't say anything further, but it may be appearing in Act 2. And finally, this is a bit of a bolt out of the blue, is TNF blockade, has yet to been studied, but is being proposed as a potential drug. This is a really impressive database, secure IBD. These are patients who have inflammatory bowel disease, who have been given various immune modulators and have gone on to get COVID-19. There's been 877 as of the date of pulling this registry. As you can see, in particular, those receiving tumor necrosis factor inhibitors, in this case, it was a mix of etanercept and infliximab. You do see a dramatic low number of death events, 1% and 2% in this case. And I would compare that to oral steroids, which the IDSA at this point has not recommended using for patients with COVID. Again, it's used in a lot of various different diseases, including Kawasaki syndrome, which has recently been described in a number of children in New York City to have gotten in conjunction with COVID-19. Weaknesses here, again, similar infections, cytopenias. There is some anaphylaxis described and potentially cancer in long-term use. So in conclusions, this is really kind of an impressive and unprecedented time where we have an opportunity to look at anti-inflammatories for a deadly viral disease. I would caution, as Jesse was saying earlier, for off-label use outside of clinical trials. The drugs at this point, again, in single-arm studies and in historical comparisons, that there is a reduction in fever and cytokine storm, but time to recovery mortality data are really lacking. There's an unclear impact of virus control and secondary infections, thromboses, or cytopenias, especially in short-term use. And there are more classes than can really fit in 15 minutes. I think there's close to 60 trials at least currently underway. And steroids are not recommended at this time unless in a clinical trial. Sorry, Hulk. So a lot of people to thank. I don't have time to mention everyone, but as Anesh said, special thanks to all the patients, the staff, especially nurses this week and always, and for my family for forbearance.
Thank you so much. That was a wonderful overview. Last but not least, Xanthia Wiley is a fellow UAB Blazer alum, I found out today. She's an assistant professor of medicine at Emory University. She's infectious disease faculty at Emory Midtown, where she serves as the director of antimicrobial stewardship. And she'll talk today about another hot topic, convalescent plasma. So welcome, Xanthia.
Thank you. Can you hear me?
We can.
Fabulous. Okay, so last but not least, let's talk about convalescent plasma. I have nothing to disclose. So testing an old therapy against a new disease. So the use of convalescent blood products for treatment of infections is not novel. Back in 1890, we used convalescent serum for diphtheria. We've used convalescent plasma for treatment in Ebola. And now we'll talk about convalescent plasma use in COVID-19. So we have a schematic here, and what you see here on the left is an infected, we're going to assume febrile since the patient is red, COVID-19 patient who undergoes full recovery. After recovery, they have blood drawn with isolation of virus neutralizing antibody. And that virus neutralizing antibody will be within one of the blood products, in this case, plasma. And then what happens is there is infusion of the neutralizing antibodies within the plasma into a COVID-19 patient. We're not going to talk about prophylaxis during this talk. So what I would like to do is take you all through 3 manuscripts that have been published within the last 6 weeks with regards to COVID-19 and convalescent plasma. So this first one, all 3 of these are out of Wuhan, China. So this is a treatment of 5 critically ill patients. This is an uncontrolled study, case series. It was e-published at the end of March in JAMA. And let's talk through some of the clinical characteristics in this first study. So again, we have 5 patients. 3 of the 5 patients were male. They ranged in age from the 60s to 70s. None of the patients were smokers. And with regards to comorbidities, only one of these patients had a comorbidity, and that was patient number 2, had hypertension and mitral insufficiency. With regards to disease presentation and course, so the estimated incubation period ranged from 1 to 15 days. What we'll do, let's go down to the interval between admission to the hospital and plasma infusion. So that also varied between these patients between 10 to 22 days. All of these patients were critically ill in the ICU with severe ARDS. It's very important also to notice that these patients received convalescent plasma. However, all of them also received other treatment for COVID, including steroids. They all received methylprednisolone. They all received antivirals. 4 of them received lopinavir ritonavir, which is one of our antiretrovirals that we use for HIV. There was use of interferon alpha in 4 of these 5 patients. And as both Anesh and Vince alluded to, the drug favipiravir, which is an antiviral used for influenza in Asia. So yes, these patients received convalescent plasma, but they also received other treatments. What were they looking for? Okay, so what they measured was, we see 4 different figures here. Cycle threshold of the virus, B was a SOFA score, C was PaO2 over FiO2, and last was temperature. And they looked at this over time post convalescent plasma transfusion. So back in A, with regards to the cycle threshold, essentially the higher the cycle threshold, the lower the viral replication. So essentially, patients with time had decreased viral replication. The SOFA scores in all 5 of these patients over time in general declined. The oxygenation over time increased, and the body temperature of the patient trended down. They also looked at IgG, IgM, and neutralizing antibody titers. So remember from that initial schematic, it was important to have neutralizing antibodies. Also looked at this with time post-transfusion. So as you can see in each of these, at post-convalescent plasma transfusion, there was an initial rise, and then most of them settled out. So these were the primary outcomes, some clinical outcomes, as well as looking at IgG, IgM, and neutralizing antibodies. So what were their overall findings? And we're going to just kind of go over the short and sweet of each of these. So what the authors concluded was that, yes, this was an uncontrolled case series of 5 very sick patients, but they felt that there was improvement in the patient's clinical status. They did comment that this was a very small sample size with a limited study design. And I think most importantly at the end, what they say is, we feel like this warrants further evaluation in clinical trials. So this was the first case series, 5 critically ill patients. A week later, let's get to the next, okay. A week later, there was another case series, this time of 10 patients, looking at the effectiveness of convalescent plasma therapy in severe COVID-19 patients, again, published April 6th, e-published April 6th. So we have 10 patients this time. 60% were male. The average age was similar to the first case series, with 34 to 70s was the age range. They were all classified as having severe disease. 3 of these patients were intubated and with multi-organ system failure, unlike the first trial. Let's go to days of convalescent plasma therapy from symptom onset. Again, there was a pretty broad range from 10 days to 20 days. What were the patient's symptomatology? The principal symptoms were pretty classic for COVID: fever, cough, shortness of breath, chest pain. There were a couple of patients who had GI symptoms of diarrhea, nausea, and vomiting. And with regards to comorbidities, remember the last study, they had 1 patient with comorbidities, and this one there were 4. Each of them had, 3 had hypertension and 1 had cardiovascular and cerebrovascular disease. What outcomes did they look at in these 10 patients? So you'll see they looked at some laboratory data as well as O2 sets. And the dotted line on each of those is the reference values. So CRPs in 9 of the 10 patients were elevated at baseline. 90% of the patients had relative lymphopenia before convalescent plasma treatment. The O2 sats I thought was interesting because only 3 of the 10 patients had sats of 90% or less before convalescent plasma treatment, with a trend towards improvement. You can see the aminotransferases here. Most were within reference range. And with regards to the total bili, there was 1 patient who had an elevated total bili, both at baseline and after convalescent plasma treatment. I won't go into the antibodies for the sake of time, but what they also did was, get this to advance. In a few of the patients, they looked at some radiographic findings as well, and wanted the reader to note that pre-convalescent plasma, on the left, we see their initial imaging, and then on the right, and some of the patients, they noted some radiographic improvement. So what was their bottom line? So again, what they said was, yes, we know that there are only 10 patients. We don't have a control group. This is a case series again, but they felt that convalescent plasma was well tolerated, could result in a significant increase or maintenance of those neutralizing antibodies that we've already said are important, rapid disappearance of viremia, improvement in clinical symptoms pretty rapidly, and radiographic improvement. Again, the very last sentence, what they also say is randomized trials are warranted. So right now we have 2 case series, both uncontrolled. And next, this was published on April 15th, which is another trial, or what I'll say is case series of patients with COVID-19 in Wuhan, China. So there were 6 participants in this uncontrolled case series. And here we have half were male, half female. With regards to age, they ranged in age from 28 to 75. 2 of the patients in this group had comorbidities, including bronchitis and Sjogren's syndrome. What they did in this case series was essentially they took each patient and they showed a timeline and radiographic changes from those patients. So what I'm going to do, what we'll only look at is patient number 3, which is a 56-year-old male with bronchitis. So this patient's timeline, he had a positive COVID swab prior to admission on February 3rd, was subsequently admitted to the hospital on February 12th. However, even before he received convalescent plasma, he had 2 repeat COVID PCR swabs, which were negative. Prior to administration of convalescent plasma, this particular patient received 3 doses of plasma therapy. It definitely differed in the other 5 patients. There were patients who received only 1 dose. So on March 5th, the patient received, had labs done to start that showed an CoV-2 IgM of 272 and IgG of 72. Received plasma on the 5th of March, the 6th, and the 9th. In between the convalescent plasma infusions, they did another COVID PCR, which was negative. Post-convalescent plasma infusion, they rechecked IgM and IgG antibodies, which, not surprisingly, were increased. They did another COVID swab, which was PCR negative, and then the patient was subsequently discharged. And what they also did was they shared some radiographic images from each of these 6 patients. Essentially, in most of the radiographic imaging, they wanted the reader to note that there was some radiographic improvement. So this was done for each of the 6 patients. Again, with regards to the plasma therapy, it was given on average of 10 to 20 days after onset of symptoms, and the PCR findings were different for each of the patients. So what was their overall finding? So what they said is, this is preliminary data, but we feel that it's efficacious. They thought that it showed effectiveness in improving the patient's symptoms, improving some of their radiographic abnormalities, and also they state, similar to the first two studies, that we do need randomized controlled trials. So these 3 manuscripts over the past 6 weeks, just to recap, are all case series. We do not have a control group in any of them. Essentially, we have a total of 21 patients. So what does one do with that? So if you ask our FDA, so what our FDA says is that although this is promising, convalescent plasma has not yet been shown to be efficacious. And again, I think everyone agrees that it's important to determine this via clinical trials. What the FDA, if you go on there, if you Google FDA convalescent plasma, they recommend, or they will offer, 3 pathways for the use of investigational COVID-19 convalescent plasma. Number 1, within clinical trials. Number 2, within expanded access, such as the National Expanded Access Treatment Protocol. And number 3, single patient emergency investigational new drug program. So if you go on their site, they will give you directions on how to proceed with all of the above. So with regards to clinical trials for convalescent plasma COVID, so as of last night, there were 58 studies that I found on clinicaltrials.gov. When I looked on Monday, it was 48 studies. Where are they? So the majority are in North America, 20 are in the United States, 8 are in Europe. What does the CDC say about convalescent plasma? So if you go to their site, there's information for clinicians on investigational therapeutics. As of April 25th, Very similar to what the World Health Organization and the FDA states. They say that there's no drugs approved by the FDA to treat COVID. However, they do send the reader to the recently published NIH interim guidelines for the medical management of COVID-19. And all of this is readily available online. So with regards to the NIH guidelines, what do they say about convalescent plasma? So in general, again, everyone says that there's nothing that has been proven to be safe and effective, and that there's insufficient clinical data to recommend either for or against the use of convalescent plasma for the treatment of COVID-19 with an A3 recommendation. I won't go through most of the society guidelines, but with regards to the Infectious Diseases Society guidelines on management and treatment of patients with COVID, they go through some of the treatments that we've actually already spoken about earlier. But recommendation 7 with regards to convalescent plasma versus no convalescent plasma for hospitalized patients, what they say is if it is going to be used, that ideally it should be done in the context of a clinical trial. So I think all of us have been saying this throughout this talk. So the bottom line with regards to convalescent plasma and COVID-19 is we need randomized controlled trials. Fortunately, there are plenty of groups enrolling, and essentially there's more to come. So thank you, everyone, and that concludes my section.
Thank you very much, Cynthia. That was wonderful. We do have a few minutes, and I would love to get our panel here to talk about, to answer some questions that we've had from our listening audience and those who submitted them earlier, if that's okay with you guys.
Absolutely.
We'll start since Jesse started with chloroquines, and feel free for everybody to weigh in on these because you're certainly all wonderful infectious disease physicians and know lots about all of these topics. But one question we had submitted was, should chloroquines now be removed from treatment guidance for COVID-19? And the question was due to adverse effects, but I guess I would add in there for lack of efficacy at this point, or lack of data for use.
Yeah. So I think especially with the Infectious Disease Society suggesting use in the context of a clinical trial, I think that most of those guidelines that came out in hospitals around the country, those were not in the context of a clinical trial. And what we've seen is is hospitals slowly updating their recommendations and hydroxychloroquine disappearing from those guidelines. And I would be in favor of removing it from a guideline. It's no longer recommended here at Piedmont Hospital, and with the exception of use in a clinical trial.
That's great, thank you. So a question about, let's go to convalescent plasma. I'm gonna mix it up a little bit. I think there is a question about the practicality of convalescent plasma. If you have a patient that is potentially appropriate and interested in a known experimental therapy, and either the patient or their authorized representative is able to have an informed consent for that, where the patient's able to get that convalescent plasma, is it available to them? And what is the practical timeline for when we'll be able to use that, in these patients?
Absolutely. So that's a great question, and we get that a good bit. So what I would recommend is if you literally Google FDA convalescent plasma, they will show you a link to the blood bank with explicit instructions for patients who have recently had COVID and may be interested in donating later. They let you know that, you should be symptom-free, ideally 14 days after your symptoms have resolved. There are a few other very user-friendly questions for the patient to answer, and that website will actually let them know when it's okay for them to reach out to particular blood banks. And if I'm not mistaken, I think there's situations where the blood bank may actually reach out to the patients. So, if you have patients with COVID who are being discharged, want to know what they can do in the future, that information is available on the FDA's website. With regards to when this will be readily available, I don't think anyone knows the answer to that just yet.
Thank you. That's great. This question was submitted via chat and was directed at Vince, but certainly everybody take the opportunity to answer. Was about the role of plasminogen activator inhibitor 1 medications, if there's a role for those.
Yes, really great question. So there's at least one drug, rapatidine, I think is used in histamine conditions. And then there's a couple of others that are out there. To my knowledge, none of them, and again, these things, as Anthony had mentioned, change by the moment, but none of them are being explored in COVID-19. But I think it's not an unreasonable thought, at least from I'm not a hematologist and sort of clotting expert, but I can't imagine there would be specifically contraindications to those drugs. I think they have the usual sort of hypersensitivity issues that a lot of these other immune modulators have, but might be worth exploring.
Thanks. We have a question about remdesivir and a dose escalation study that may be underway. That was, I think, for Anesh, but anybody feel free to take that.
Sure. So Gilead, and I don't have a lot of communication with the company itself, but I know they have been looking at 5 days versus 10 days of therapy, both for moderately ill patients and severely ill patients. And they have some indication that they've released, not in any scientific way, but just in press releases, that 5 days may be sufficient for many patients. So I think we are waiting to see that data. And given the shortage of remdesivir, if there is a good indication that, at least for certain patients, 5 days would be as good as 10 days, then we may be able to expand the supply very quickly.
Thank you. We had another question that was answered in the chat, but I thought it was actually a really good one, and the rest of the audience might be interested, about whether there was any correlation between HIV positive patients that are on antiretroviral therapies and those that aren't, and COVID infection, their presentation, and the severity of illness.
I'll begin by answering this. I've taken care of patients with HIV and COVID-19, and I've seen a broad range of outcomes. At this time, I don't see any evidence that they're any different than individuals who do not have HIV and are not taking retrovirals. I think there is hope. I've received questions from my patients with HIV. Do my medications help me? Are they protecting me from COVID-19? At this time, we don't think that's the case. I don't think that antiretrovirals are protective against COVID-19. And so I would take all of the same precautions that the rest of us are taking.
Yeah, and I agree with Jesse entirely on that. We've had, I was mentioning in the chat reply, we have about 10,000 patients in our Emory-associated HIV clinics actively seen over the course of a given year. And we've admitted about 20 so far. And I think largely that has been due to either one of two things. Either our patients with HIV have less severe disease, or they're going to really significant measures to avoid large crowds or places where they could get SARS-CoV-2. So social distance, physical distancing measures have perhaps been enhanced. There's also some thought that either people with especially in our PONS clinic, Grady Clinic, where there's a lot more immunosuppression from HIV, meaning advanced AIDS and the like, advanced HIV, that maybe there's some, if they get SARS-CoV-2 infection, there may be a lower rate of going on to severe disease. And that's unclear, that's just a theory, but it makes sense if their Th1 axis is hindered because of HIV itself or AIDS. But yeah, again, we haven't seen anything, even in the in vitro work that's been done at Emory, to show that treatment actually is preventive.
Thank you. I have a little bit of a curveball. This one's not for anyone in particular, so you guys take it. But we're seeing media reports about different strains of COVID or SARS-CoV-2, and the question is, does treatment vary between those different strains?
So I'll try to quickly answer that, and I'll depend on my smarter colleagues to try to correct me. So far, we have seen a lot of minor strain variation, which allows epidemiologists to track sort of the spread of disease. We haven't been able to link too many of these mutations or changes or strain variations to changes in clinical phenotype, but that research is ongoing. As far as we know, the direct acting antivirals, the ones that I mentioned in my talk, don't seem to have much difference in the strains, but again, it's really early. So I think there's got to be a lot more research before we can say anything definitive about that.
That's a good answer. Anyone else? Great. One more question. This one's a little bit broad too, but feel free, anybody. How do you counsel patients or patients' family on experimental therapies for COVID-19 illness? And that this could be, I think, in the context of clinical trials versus those that are doing expanded access protocols or the EIND process.
This is Anthea. I'll take that one. So I think it's very important to let the patient and the family members know that, number one, just make it very clear to them, we don't have a specific treatment for COVID. Use of this medication, if the provider elects to use it, there are risks. Some of the risks, let's say if someone decided to prescribe hydroxychloroquine, I would let them know that there are patients who have had heart abnormalities from it and kidney abnormalities from it. There are some limited studies that show some improvement in some patients. However, we don't know, and we want to counsel you and let you know that there is a risk of taking it. So I think the most important thing is being extremely upfront and saying that there is no evidence that this works. Because what I found early on is, especially with hydroxychloroquine, people were asking for it. I mean, before you can even mention anything about it, I want the medication that was mentioned on TV. My friend tried X medication. I would like it as well. It was on our treatment guidance very briefly, very early on. And, we made sure that we, documented that this is not FDA approved. These are some of the side effects. And what I found is that some patients were like, no, thank you. But there was so much fear early on, especially, late March, early April, that a lot of patients accepted it and took it and were convinced that it made them better. So the bottom line, I think, is being very upfront, saying that this is not FDA approved.
Thank you. So one more question, actually getting back to hydroxychloroquine, was about there was a recent preprint in Travel Medicine and Infectious Disease by the same French group that published some of the early non-randomized data on chloroquines and azithromycin. And just asking about that particular experience, and if anybody's had a chance to review that article and their thoughts on it.
Yeah, I can talk about those articles. So the first article that was published in April in Travel Medicine and Infectious Diseases, that is non-comparative, so they didn't have a control arm. So that it's hard to really get a lot from that article. And I'll caution that that first study that I presented out of Marseille in France, the final author on all of these publications is Dr. Raoult, R-A-O-U-L-T, and he has stated that he really doesn't believe in the use of randomization and randomized clinical trials. And that's a problem because it's really hard to address confounders in that situation. Now, the other study that was published on Monday with 1,061 patients, that one they really also don't have a control arm. It's an unusual study. It's really hard to know what to do with that. They looked at poor outcome, which included mortality and ICU stay. And then they looked at the measured blood level concentration of hydroxychloroquine, which is not something we really use clinically. We either give a medication or we don't. We don't look at drug levels. And so I think that there's the clinical utility of both these studies is poor. And I don't think they changed my recommendation.
Thank you very much. I think we are nearing the 3 o'clock hour, and I know we're all very busy clinically and with our other duties. So I wanted to thank everybody on our panel today. This was a wonderful session and just an honor for me to host my my Avenger friends in infectious disease. That was great. So thank you, everybody, and please stay tuned. We'll have some announcements going out with links to register for our next session. So part 3, we'll talk a lot about testing and immunology. There's so many questions right now about PCR testing and antibody testing and the strategies. So hopefully we'll have a good discussion on that. We're anticipating next week and gonna announce that as soon as we get it set. So thank you, everybody. Thank you to our panelists, and look forward to posting this for everybody to review later. Thanks, everyone. Bye.
Thank you, Amy.